Welcome to the end of January grand rounds. This month, we're going to do something a little different than usual. So we are going to hold a more traditional grand rounds from the medical training sense. So we're going to do some case presentations, and we hope that there are good nuggets for you all to learn. And once again, towards the end, you'll be given the opportunity to let us know how you think this is going. So to get us started, I'm going to turn it back over to Christy, who will explain all about CME and how to do that. Go ahead, Christy.
Excellent. Thank you. And we will get our slides up there. One other thing is all of our speakers sign a disclosure of any prohibited relationships. This is our declaration for this session that none of our speakers rather have any prohibited relationships to disclose. Next slide. Thank you. So these are the objectives for what we're going to talk about tonight. We will be discussing case studies related to color vision and specifically color vision screening. We'll also be talking about hearing and ears. And then we will also have a case study at the end with Dr. Donnelly. That is airman certification for high-risk diseases. That's it for me. I'm going to turn this over to Dr. Frazier. Thank you.
All right, thank you, Christy. So we're just going to do a couple of case scenarios of things that we have seen with the color vision rollout that happened January 1st. So the first scenario, 53-year-old first class, 9,000 hours, comes to see you for their first exam with you after their previous AME retired. They have a first class medical certificate. All it has on it is not valid for any class after 12/31/2024. How do you handle the color vision portion? Remember, we talked about the buckets of who needs to be screened and who doesn't. This is an experienced pilot who does not have a prior SOTA, LOE, or limitation. He has previously passed an acceptable color vision test. All you have to do as the AME is mark pass in item 52. And then you should be able to issue, but just remember to figure out why he has a time limitation on his prior certificate, but it's not from color vision. So scenario number 2, this pilot is 17, first class, 4 hours, comes to you for their very first FAA exam for flight school. You don't have a color vision computer-based test yet. It's supposed to be scheduled to deliver next week. And the pilot says, I have to have a medical today, doc. I have to have it for school today. What do? So do you issue a first class with limitation 104? That's the limitation that says valid for VFR only. Do you issue a third class with limitation 104? Or do you issue the first class he asked for, no limitation, because the individual said he could see all the stoplights on the way over, and that's close enough for an FAA color vision test? So correct. Third class, limitation 104, he can get a certificate that day. So remember, it has to be third class with the limitation. So then this same pilot, 3 weeks later, comes back and says, hey, I found an eye doctor down the street who has this thing called a Rabin test, and I took it, and here's my results. Rabin, the passing score for FAA purposes is 55. Everybody needs to note, currently in the AME guide, it says 75 for each color. It's 55. So anybody who has a 55 for each color will pass the Rabin. If the pilot brings you this documentation signed by the provider who administered it, you'll be able to accept this. Remember, you've already given them a certificate. It's already uploaded. That exam is gone, but you can upload these documents into AMCS so that we can look at them. So what you do now, you just tell the individual, oh, sorry, can't have anything other than third class. Or do you say, nope, let me do a new first class exam, and I'll get you another certificate? Or do you just have the individual complete a color vision limitation review and upload that into AMCS with a copy of the test results? So the answer is C. Remember, he just had an exam 3 weeks ago, so if you try and transmit another exam, it's not going to let you. And he doesn't need a new exam. He just needs an upgrade with a passing test. In the AME guide, you can find this document. It's the color vision limitation review. This is how we can find these cases in our system without having to wait through the normal time process. So your pilot passed a color vision test, wants a first class. We need the color vision test results, and we need this page called color vision limitation review. Next scenario, 35-year-old second class has 210 hours, brings in an old letter of evidence and says he wants it removed and he wants a first class certificate. You do have a computer color test. What do? You administer the new computer test and almost passed, really almost passed. What do you do next? Do you administer the same computer test again? Do you defer? Say the individual failed, they will never be able to obtain a medical certificate again? Or do you issue a second class with limitation 104? In this scenario, the correct answer is administer the computer-based test again. Remember, those computer tests were chosen because they're random. So if you give them the test again, it's a different test. It can still accurately identify a color deficiency. If the test results look like what you're seeing on your screen, this is a scenario where they have passed. This is an example of the Wagner. So you'll see at the top, it's the adult diagnostic. The other name you might see is the FAA color test. For adult diagnostic, general section has to be 21 or higher, and Triton has to be 10 or higher. The screen on the right shows you a picture of the AME guide score results. You can find this in the AME guide. This is an example of a pass. So in this case, AME actions, the individual passes. They don't need a SOTA or an LOE anymore. If they want a first class and they have the passing result we just looked at, you can issue a first class, upload the test result under EYES color vision test results. This individual now from here on out can get a SOTA, or can get a first class medical certificate, no longer needs an LOE, no longer needs a SOTA. One of the questions that came up at the last session is if you're doing the computer test in your office, do you have to print it and sign it and then upload it? If it's your own test in your own office, just tell us that in block 60, you did the test. If somebody brings in a test from an outside provider, that's when we need a signed test report so that we have some validity that it was an accurate test. So same pilot, but let's say they come back and retake the test, and this time the results show general section 05, which is fail, and the Triton was 312, also a fail. Remember, if the general section of the Wagner does not give a passing score, it's going to give them a proton and deuterium test, and they have to pass both of those. So the scenario that you see here with pilot number 3, they did not pass a computer-based color test. They have a second class LOE. Their ability to upgrade to a first class, they cannot do that with this test. So in item 52, what you're going to do is mark fail. You're going to upload this color vision test under EYES color vision test results. You're going to issue a second class medical certificate. It's the same thing the pilot had prior to taking the computer test. And just inform the individual that they do not get an upgrade. They stay with the existing SOTA or letter of evidence. Remember the take-home sentence on this slide. The pilot should walk out of your office with the same limitation SOTA or LOE they had prior to January 1st, unless they've passed a computer-based test. So some common errors that we've seen. We're seeing AME offices upload the test and the limitation review under the same tag. Please separate that. Again, to get the limitation review done quickly, we do those every Monday. We need it uploaded under EYE color vision limitation review. That's the one page that the pilot fills out that says why they want an upgrade. And then always put the color vision test under EYE color vision test results. The other thing that we've seen is AMEs issuing a first or second class with limitation 104. 104 is the day VFR only. Just remember, Third class 104 is there so that the pilot can get a certificate day of service, day that they see you. If they fail a test, they get a third class with 104. If you don't have a computer test, they get a third class with 104. If they want to upgrade, then they need to get a test they pass, and they need to use the eye color vision limitation review. So last scenario, you have a pilot who's also an air traffic controller. They come in for their routine follow-up exam. They also want their second class medical certificate that they've been getting for years and years. They do not have a color vision limitation. What do? For the air traffic portion, remember the air traffic requirements have not changed. So whatever you did prior to January 1st, you continue to do. So they still need a color test. For the pilot medical certificate, this pilot already has a previous medical certificate. They do not need color vision computer-based testing for their pilot certificate. So again, air traffic, they need to have the air traffic test. It's any of the computer-based color tests plus some of the older tests. Those are still in the AME guide. And with that, I'm going to turn it over to Dr. Sigmund to talk about ears and hearing.
Thank you, Judy. And good afternoon, everyone. Thank you for being here. We appreciate you joining us for the AME Grand Rounds again. This is a wonderful opportunity for us to present information to you. As Dr. Northrup mentioned, today we're doing a traditional Grand Rounds and presenting some information related to certification cases that you might come across, and certainly that we come across fairly frequently. I'm Jason Sigmund. I'm an otolaryngologist with the FAA. I'm also a medical officer in Aerospace Medical Education Division. Today we're going to talk about a case related to hearing and discuss the hearing standards. Next slide, please. So this is an airman who applies for an FAA medical certificate. He undergoes an AME examination in your office, and he fails the conversational voice test. And this doesn't happen very often. 99% of airmen who come into your office for AME exams, as you guys are men and women, our AME workforce are very well aware, it's very, very unusual for a pilot, an airman applicant, to not pass the conversational voice test. However, if only 1% of the time an airman doesn't pass the conversational voice test, with over 400 to 450,000 airman applications every year, we'll see 3,000 or 4,000 examples of pilots who don't pass the conversational voice test. We want to talk about what to do when that happens. So our discussion will include the Part 67 standards as it relates to the qualifications for hearing, the examination, and certainly the disqualifying conditions, and how they relate to aviation safety as it relates to hearing and speech and communication. Next slide. So keep in mind that if your airman comes into the office and does not pass the conversational voice test, that we do have the opportunity to try 2 other diagnostic testing to meet the standards in 67105. Again, conversational voice test is one under 67105A, but number 2 and number 3 provide additional opportunities, and the airman only has to pass one of the following tests. The audiometric speech discrimination testing score of at least 70%, that is typically found on a traditional sound booth audiometric test. Some of the AMEs may have access to that in their office, depending on their specialty, or the clinic where they work. But most of those are available within the community. And so keep in mind that if you do have a pilot who doesn't pass the conversational voice test, you can hold that examination for the period of time that's allowed, for 14 days, and have the airman go and get an audiometric test in the sound booth. And if they pass the speech discrimination to that threshold of 70%, not utilizing more than 65 decibels on the loudness level for that test, then that passes. That meets the standards for 67105 for hearing in a pilot who doesn't pass the conversational voice test. Again, there's also number 3, which is our pure tone audiometric testing. This isn't available as commonly. It used to be more common that primary care offices and even some of our AMEs would have pure tone testing where they would put on headphones, not dissimilar to the ones that I'm wearing right now, and have presented to them at standard levels 500 to 3,000 hertz And there is a table within your AME guide that shows the better hearing ear and the worse hearing ear and the acceptable thresholds that also qualifies to pass the hearing standard in 67105. Next slide, please. Now, in this case study, this pilot did not pass the conversational voice test as we discussed, but audiometric evaluation and speech discrimination score was 75%, which meets the standards under 2 for 67105A. However, the pilot has been deaf on the left side since birth, so they only have hearing in the right ear. They do meet the discrimination threshold standard for 67105A under number 2 for speech discrimination. However, in the history, the pilot had a history of fluctuating hearing loss, requiring steroid therapy to recover hearing in the only hearing ear. Next slide. So does the airman satisfy all the Part 67 standards for certification as it relates to ears and hearing? Well, the answer is maybe. Again, the pilot certainly meets the standards under 67105A under test opportunity 2. But remember, we also have 67105B, which covers the general medical conditions of the internal ear or middle ear that would affect clear and effective speech communication. So that covers other medical conditions. Keep in mind that pilots who have vestibular disorders, even acoustic neuroma, labyrinthitis, Meniere's disease, and other diseases of, or conditions, medical conditions of the inner ear, all of them will most likely, typically pass one of the standards for hearing under 67105A. So that history is very, very important. Just because they meet the standards of 67105A, it doesn't necessarily meet all of the ear, nose, and throat standards as it relates to hearing. Next slide. And that standard is here for us, which is 67105B. No disease or condition of the middle ear or internal ear that interferes with or is aggravated by flying or expected reasonably to do so, or interferes with or may reasonably be expected to interfere with clear and effective speech communication. And of course, we have C, which covers any condition that could cause disequilibrium or vertigo, obvious aviation safety concerns. So in this pilot who has met the standards under speech discrimination under 67105A, under 67105B, there is a condition, fluctuating hearing loss, that we could reasonably expect to interfere with clear and effective speech communication. Next slide. So in this case, the airman meets the standards for hearing, but do they meet 67105B? And again, this becomes a question of whether, in the interest of aviation safety, one considers the history as reasonably expected to interfere with clear and effective speech communication, which it most certainly does. So the recommendation in this case would be to defer. Next slide. So what happened after that deferral? Well, in this case study, we sent out an information request. We requested a detailed clinical progress note from the ear, nose, and throat physician and all the prior audiometric records surrounding the episodes of the prior fluctuating hearing loss. The findings for that information request was that the pilot had 3 prior episodes with audiometric evidence of hearing loss that was in the severe to profound range and had speech discrimination scores that were less than 50% on all of those 3 prior episodes. Further evaluation by the ear, nose, and throat doctor revealed that the MRI was negative, looking for other contributing pathology that might be accounting for the fluctuating hearing loss, such as an acoustic neuroma, which will sometimes present as such with those symptoms, and the working diagnosis was idiopathic fluctuating sensorineural hearing loss. So now that we have this additional information, what is our recommendation? What's the rationale behind that as it relates to aviation safety risk management? How do we mitigate this as it relates to safe decision making for medical certification? And again, a little hint there is that when we see idiopathic and that technically is unexplained, we have to keep in mind that also triggers thoughts about the specifically disqualifying conditions of having any symptom related to the peripheral or central nervous system without a satisfactory explanation of cause. Next slide, please. So the eligibility determination decisions in this case study, this is an airline transport pilot. He's 60 years old, and he has fluctuating hearing loss in an only hearing ear. Well, it can vary. It could include denial based on the certificate class and the associated pilot privileges that are exercised under specifically disqualifying condition that I mentioned, and 67105B, it's reasonably expected that this could interfere with clear and effective communication in the cockpit. Another opportunity would be for a certificate restriction. I believe that restriction is number 22, which is no fly where radio control required. And we do have pilots, many pilots operating with medical certification with limitation 22 for no fly where radio control is required. That could, an example that may potentially be a deaf pilot. Certain pilots that are deaf in the deaf community haven't undergone or elected to undergone cochlear implantation. And so they fly under this limitation. The other additional hearing limitation that we see for medical certification would be limitation 9, which is must use hearing aids for those pilots who have to use hearing aids in amplification or cochlear implantation. Next slide. So in the follow-up in this case, this airman experienced another episode without recovery of hearing with supportive care and time. So steroid rescue and some additional time didn't recover the hearing, and that's not unusual in individuals who have fluctuating sensorineural hearing loss. Is at some point it just doesn't come back. Just an analogy would maybe be Bell's palsy. Most individuals who have Bell's palsy will be on steroids and potentially antivirals, and their facial nerve function recovers, but occasionally it doesn't. And the same thing is true for sensorineural hearing loss. It's just one cranial nerve lower than the seventh nerve, number 8, and sometimes it doesn't return. And that was what happened to this pilot. And this pilot underwent cochlear implantation because now they're binaurally deaf. And after an adequate period of recovery and follow-up audiometric testing, plus we did a medical flight test in the simulator. It was a 787 Dreamliner, in fact, and that pilot is back in the cockpit. Please put any questions in the Q&A and I'll answer those. I'm going to turn the floor over to Dr. Donnelly to go over the high-risk management certification case. And again, thank you very much for participating in our grand rounds.
Well, good evening. Thanks for coming out tonight. I'm glad to be here and have a chance to present this interesting case to you. So in aviation safety, we're appropriately averse to unnecessary risk. But the question came up as a result of this case, is there ever a safe way to accept what clinically is considered very high-risk disease? And in this case, we're going to look at a disease that we all encounter on a pretty regular basis. But the unusual way in which it presented here, I think offers us some lessons to learn. Next. So our case presentation begins with an 86-year-old third-class 800-hour pilot with an elevated PSA. Now, when I say elevated, I mean to the tune of 63. For reference, I'm sure most of you already know this, but for reference, normal is considered less than 2.5 in all men and less than 4 in men greater than 60 years of age. Normal is also a relative term. I know that there's some variability in interpretation, both among the practitioner as well as the individual patient. But in any case, whether you're using a cutoff of 4 or 5 or some other number, it's likely much less than 63. So in this case, an elevated PSA is going to warrant additional clinical surveillance and/or investigation. Next. So the urologist and the patient in this case decided that imaging would be the next step in the evaluation of this prostate cancer. And they did so by way of a prostate MRI, which showed a large PIRADS 5 lesion. Now, the PIRADS might be an unfamiliar term to you all, so I just wanted to share a little bit of background on this. The American College of Radiology has developed several, so far 9 to be exact, with 6 more in development, reporting and data systems. And these tend to be disease-specific or organ system-specific to allow for standardization of interpretation and communication of findings between different radiologists or pathologists or other practitioners that would be using the imaging. And this allows them to, in shorthand, communicate risk effectively, and it's used in many protocols for decision-making purposes. In this case, the PI stands for prostate imaging, and that's specifically the reporting and data system that we're working within. Most of the PIRADS classifications, or most of the RADS classifications, PIRADS included, terminate at a high number of somewhere between 4 and 6. In the PIRAD system, 5 is the highest number, and in this case, it indicates clinically significant cancer is highly likely. Next. Because of the risk associated with the imaging, a biopsy was the next logical step from a clinical investigation standpoint. In this case, the urologist used a procedure called a UroNav prostate fusion biopsy. I don't have any tie to UroNav. I'm not promoting it or advocating for it. I'm just reporting that that's what they used. But what is it? Well, it is a multiparametric magnetic resonance imaging, or MRI, plus a transrectal ultrasound used to guide a needle biopsy, with which they get numerous cores from the prostate. So in this case, having done this biopsy, they found a pathology result that was positive for ISUP, which stands for the International Society of Urological Pathology. And the ISUP grade group was grade group 5 for prostate adenocarcinoma. We'll talk more about the grade grouping in a moment and more about the pathology in a moment. Next slide, please. Before we get to the pathology discussion, I want to also mention that in addition to the biopsy, they did a prostate-specific membrane antigen PET-CT. Now, the PSMA is a radioactive tracer that binds to prostate cancer cells. It's often used in conjunction with CT or MRI. It's quickly replacing the traditional PET scan for whole body evaluation of metastases. In this case, the whole body evaluation constituted the vertex of the head down through the mid-thigh to include all of the pelvis. Next. So back to pathology. First of all, it was unfortunate, but I didn't have the full pathology report that came from that biopsy. I did have significant notes from the urologist's report, and from that I gleaned the following. So we have a CT1 CN0 M0 tumor. In this case, whenever you see the little letter C before the TNM classification, it implies that the evaluation was made based on a clinical basis, as to sometimes you'll see a P, which stands for a pathologically evaluated or pathologically derived classification. So in this case, it's a little confusing that we would have a clinical evaluation of the tumor, the T1 part of the TNM staging, based off of a biopsy. Well, the reality is that based off of a needle biopsy, we don't have sufficient tissue or information to consider it anything other than a T1 lesion. We don't get the same orientation within the organ or evaluation that would allow us to classify it as anything other than a T1 lesion. And it thus gets classified as a clinical evaluation at a T1 level. The clinical node evaluation is primarily a combination of physical exam and the results of the imaging scans that have been done. The fact that the PSMA PET-CT showed no metastases anywhere was reassuring and contributed to the clinical evaluation of no nodal or distant metastases. The ISUP grade group 5 implies a Gleason score of 9 or 10, but let's take a second and see what that means. Next. So Gleason was a pathologist who described prostate tissue according to patterns of differentiation or dedifferentiation. As the number increases from 1, the most differentiated, the most like normal prostate tissue, to 5, the most dedifferentiated or cancerous tissue, the number increases. So a specimen, a pathological specimen, is evaluated for all of the different grades of dedifferentiation that are in that specimen. The two most prominent then are summed together. Scores of 1 or 2 are not considered cancerous, and so when we see the pathological scoring for cancer, it's only going to have 3s, 4s, or 5s. When you have a 3+3 lesion, that means that no 4 or 5 was visible. And so the most common and second most common cancerous pattern were both 3s. In the case of the 5, of course, you get to 10 because all that was there was 5. And so you get a 5 + 5 = 10. So the scale goes from 6 to 10. Next, please. I want to point out the fact that there are 2 ways to get to 7 in this system, and they're scored differently. If you have a predominance of a Gleason pattern 3 and a less predominant Gleason pattern 4, that gets you to 7, but it's considered a slightly lower risk than if your predominant pattern is a Gleason 4 pattern. So once you get to the Gleason score, 6, 7, 8, 9, or 10, then the ISUP translated those scores into a risk stratification from 1 being the least risk to 5 being the greatest risk. And you can see how those translate there. Next. In the case of our pilot, he's in grade group 5. Now, we don't know for sure whether that means that there was some Gleason pattern 4 cancer present, but we do know that at least some Gleason pattern 5 was present and could have potentially been all Gleason pattern 5. Why that's important? Oh, back one more. Why that's important here is it goes into staging the cancer. So this is a stage 3C cancer. It's the highest cancer that isn't a stage 4. Stage 4 requires metastases in order to become a stage 4 cancer. So he's a grade group 5 and has no nodal or distant metastases. Okay, next. So when we look at the National Comprehensive Cancer Network characterization of this tumor in particular, they consider it a very high risk. Now, in the case of the 9s and 10s, those technically can be either high risk or very high risk, and it has to do more with some of the other subtle nuances. In this case, it includes the fact that his PSA is already significantly elevated. It includes the fact of his grade group. In this case, we need to figure out, well, what is he at very high risk of? Because that's important. Just saying that something is very high risk is different than knowing what the risk is. And so in this case, we're concerned about local progression, which could result in symptoms. Now, the symptoms in this case would be significant because as of right now, even with his elevated PSA, our pilot has no symptoms and no impairments. He's not on any medications and has no comorbid diseases whatsoever, at least that he's reporting to us, right? So local progression could result in symptoms which are most likely to include lower urinary tract symptoms of urinary retention, urinary frequency, incontinence, could potentially include some pain or some erectile dysfunction, but as much as anything, it probably is going to be lower urinary tract infection or lower urinary tract symptoms. The other thing that's at risk here is the risk of metastases and resulting organ dysfunction. We'll talk a little bit more about metastasis of prostate cancer here in just a little bit. And then the final risk here is the relapse or recurrence even after treatment risk. And so given the fact that he is at very high risk, you might factor that into what course of treatment he chooses. In this case, it ultimately didn't play a significant role. Next, please. That brings us to the treatment options, though. And so this information was gleaned as much out of the discussion from the urologist and the pilot in this case. And it starts with the option of observation or active surveillance. Now, you may be aware that sometimes there are molecular or genomic tests that urologists use in order to help determine how aggressive the tumor may be and whether a surveillance strategy is sufficient. In this case, that wasn't used. There wasn't really much discussion about why it wasn't used or whether it could have been used, just that I just bring it up for your awareness, but it didn't play into the discussion of this case. Next. Moving beyond just the observation or the surveillance stage, we go to the hormonal intervention of androgen deprivation therapy. Now, the goal of ADT, or androgen deprivation therapy, is to reduce the likelihood of progression or to prevent the development of symptoms. It doesn't actually cure in any way. There's still going to be the same cancer that was there. And the reality is it may not completely arrest the progression. It may only slow it, but it certainly does reduce the likelihood of progression. Next. In addition to hormonal intervention, there are also surgical options. In this case, they discussed radical prostatectomy, and they discussed external beam radiation of the prostate. There wasn't really any discussion of chemotherapy, given the fact that all of the disease is localized to the prostate. As far as the options go, it's important to also note that whenever cancer is being treated, the treatment comes with its own risks. Risks of symptoms or risks of impairment, and certainly even just the risk of being sedated for a major procedure. And so that risk has to be weighed into the decision here as well. I found it really interesting that the urologist discussed the fact that we have a lot of information about prostate cancer as a statistic, but tumor aggressiveness is something that can't reliably be predicted from one patient to another. Now, when we talk about aggressiveness, we're really talking about how quickly the tumor can develop within a specific patient or person. And so this is to say that in one person, it may present as the typical, what we think of as indolent or slow growing tumor, that's prostate cancer. In another person, it may be more aggressive and may be more likely to metastasize. In any case, that was something that they discussed specifically before making their decision. Next. In this case, the urologist recommended and the pilot selected watchful waiting. Now, this surveillance strategy is predicated on the fact that his life expectancy already is less than 10 years. Even in the best of health, an 86-year-old pilot can't be expected to live another 10 years. Some do, but that's not the norm. And so this watchful waiting strategy was definitely influenced by the phase of life. It was also influenced, though, by his good health and the fact that he has no significant impairments at this time. The idea was that he would be able to continue with his active lifestyle as he is now, and then could pursue intervention if symptoms or metastases were identified. Next. As part of the surveillance, the first data point that I received after the decision was made was just 8 months after that measurement of 63, we now have a PSA of 91. So as expected, we're seeing some local change. There was no mention of any metastases or symptoms still at this stage of the surveillance. Next. So aeromedical considerations. So first of all, we like to look at his health and the fact that he's in good health right now. He has no comorbid conditions of aeromedical significance. He has no impaired function. He's active out pursuing his hobbies or doing other things that contribute to his quality of life. All of those go in the plus column. They're things that we're interested in. Next. The next thing to look at is sort of the prognosis. Where are we and where are we likely to go? So his prostate cancer is likely to progress and or to metastasize. So what does that mean for us in terms of aeromedical consideration? Well, if he has local progression, it's likely to progress locally either to the rectum or the bladder or the pelvic wall, or the other tissues in the urethra and surrounding the prostate, where we would expect to see local symptoms. And those symptoms would drive him to seek care. The fact that he's already engaged with his urologist would have a high index of suspicion for investigating and treating any of those symptoms. For metastases, prostate cancer metastasizes most commonly to the lymph nodes, to the bones, less commonly to the lungs and the liver, and then even much, much less commonly to other organs. But these are the big four that we see pretty commonly. I had a question earlier after the presentation about the concern for subtle incapacitation, and I didn't have as good of an answer as I would like to have had. So I went back and I did a little bit of studying again this afternoon so that I could improve my answer on that. In this case, what we would be most concerned about in the area of subtle incapacitation, in my opinion, would be if it were to metastasize to brain or if it were to metastasize to the tissues of the eye. In the case of eye metastases, these typically present as blurred vision. And so it's something that is easily detected by the pilot. If it's being discussed with the urologist, it would have a high index of suspicion. More than likely, though, it would drive him into an ophthalmologist or an optometrist to be further investigated. In the case of the brain, I'm reassured by the fact that of the cancers that go on to metastasize, less than 1% of them involve the brain. Now, I know in percentages and aviation, we're quick to key in on things like that. For individual patients, though, it's either a yes or a no. But it is reassuring that of the prostate cancers that are out there, not all of them metastasize, and of those that metastasize, a very small number over the course of the entire disease presentation, not just per annum, but the entire duration of the disease, less than 1% of them have a potential for metastasizing to the brain. And those that do metastasize anywhere should be increasingly picked up by the surveillance strategy. Surveillance is likely to detect disease progression before incapacitation. And surveillance involves, first of all, following that PSA. We know that the urologist is already keyed in on this. They know that there is disease present, and they're trying to understand the behavior of the disease that's already there. So they're more likely to follow with close serial PSAs, and they're more likely to follow with close interval imaging surveillance, especially if they see increasing PSA. There also may be a tendency for them to transition from the strict watchful waiting to an androgen deprivation therapy. And so that ADT may at some point come into play, especially if they see the progression of the PSA. Next. So we come to the point of making some decisions based on the risk assessment that we've done. And first of all, this wouldn't be suited for a CACI management. And the reality is, the way that our policies are written, the only reason that it wouldn't be considered able to be managed by CACI is that the PSA is too high. So the limit for the CACI management is if the PSA is at 20 or less. And so in this guy's case, he's started out at 60 when we came to know about the case, and he's already at 90. Now, it strikes me that the risk of the disease might exceed the normal khaki management threshold by itself, but that isn't really baked in to the way that we have the khaki management criteria at this point. Next. So what did we do with this guy? Well, in this case, we did decide to issue him a special issuance authorization, but we also decided to restrict it from the normal 12-month surveillance to the 6-month intervals. Giving him a certificate time limitation allows us to look more frequently. It encourages the urologist to be more vigilant. It ensures that he's actually participating in the active surveillance. And then if we do discover symptoms or metastases, it allows us to make sure that the treatment is going to follow. We would expect any symptoms or metastases to require treatment before we would consider further certification. Metastases also can be stratified, and if it metastasized to any organ other than the lymph nodes or the bones, we would likely not consider certification even after treatment. That would show a level of aggressiveness that would be uncomfortable for us to proceed with. In the case of bones or lymph nodes, those may be able to be remediated, and depending on what the course of treatment is, both to remediate that metastasis and then to manage it in the going forward in the post-op phase, we might be able to consider further certification, but it wouldn't be guaranteed. Next. Okay, that's it. Thank you for listening. I hope this was helpful. It was definitely interesting to me as I worked the case, and I hope it will be interesting to you and useful in your management of similar cases. Over.
Okay, thank you so much, Dr. Donnelly. That will be the end of our presentation tonight. We appreciate all of you for coming, and we thank you for your interest in aviation safety. Dr. Northrup, do you have anything you'd like to close us out with, or Dr. Frazier? Email along with your first and last name, as well as your AME number, and you can request that 1 hour of credit. Keep in mind, this is a new email address, and requests for CME credit will not be answered if you send them to a different email inbox. And at some point, hopefully, we'll be able to post the recording of this. And if you're watching this at a later time, we cannot grant CME credit for watching the recording. That's all I have. Thanks everyone for coming this evening. FAA folks, stand by to go into the break room.